Starting with the burden of hemophilia, all of us being treating hemophilia patient, and we know the different morbidity and mortality, but let me post an important issue here which we usually miss, though it's a small percentage, 5% of the patients suffer of intracranial hemorrhage, and I was just having a talk this morning with Dr. Magda. We lost 2 young men suffering of hemophilia A and intracranial hemorrhage. So it's really depressing to have this percentage among our patients. And I guess Dr. Abdul Wahab is presenting tomorrow the intracranial hemorrhage among hemophilia. Then going through the different morbidities, mainly the joint affection with the arthropathy, accompanying maybe up to 80% of the patients, and showing them the different devastating effect all throughout their life. So the long-term physical impact, it's mainly the arthropathy, up to having joint replacement early in life. Then we were having the risk of blood-borne infection. This was evident during the era of the 1970s and 1980s, where around 4,500 patients in the UK suffered of hepatitis C and HIV. And it has been a long issue in the parliament. And all of us know this era, but thank God now we don't have any more viral infection, the blood-borne viral infection. And we have the issue of the venous axis, and lastly, the lifespan of the patients being around 5 years less than the normal population. But what about the socioeconomic burden? The socioeconomic burden, it's not just a matter of direct cost, the amount of replacement therapy. There are lots of other issues that has to be added, like the indirect cost, the cost of the hospital, the treatment, the physicians, the absenteeism, the patient being absent from school and his parents from the work. These account for a lot of money. So we have a huge socioeconomic burden in addition to the complications. Arthropathy, treatment of arthropathy, accounts for a big burden. And what about the inhibitors? Inhibitors, as Professor Ghamraoui just mentioned, accounts for a large population, up to 30% in severe hemophilia A, and the treatment of inhibitor costs a lot. What about the psychosocial? The psychosocial, this is an aspect which I always put in my presentation, because though I'm a pediatrician, but I've been seeing adults with hemophilia, and I see the suffering throughout the life of the patient, starting from the day of diagnosis, when I just tell the mother that your son is suffering of hemophilia, and how she reacts. The first presentation, let's say the instability, when you tell a parent about her son, sorry. And afterwards, the child coping with the school, with the nursery, coping afterwards with the joints, his joint affection, and having a period during the adolescence where the patient usually doesn't want to come to the hospital and feels different than his colleagues, and up to the adult where they need someone to help them. They cannot live normal life alone. So it's the life of the hemophilia, though the number of hemophilics is not that much, but still they need much more care from the whole community, because they need to live like any normal person. So what is the treatment? All of you know these. I'm just going to pass that WFH recommends early treatment. Why? Because this would lead to early relief of pain, better immobilization, so reduce the joint damage, and at the end, we will improve the quality of life and would reduce the cost. This is the life stream of the development of the factors, starting from the early last century, where it was only the plasma or the cryo, and up to the development of the different forms of factor, whether plasma-derived, recombinant, extended half-life, and the future, and I assure you it's going to be the near future, it's going to be the gene therapy. And the main recommendation or the main goal is to prevent, which is the main issue, is to prevent bleeding, whether by the deficient factor or by other replacement therapy, and in a comprehensive setting. Why do we not give the correct amount of factor everywhere? Because we have to choose. There are two main things we have to put in mind while choosing which factor to give to the patient. The first thing is the efficacy. It has to be efficacious, meaning that it has to control bleeding. I have to know which factor therapy I should give to which patient. And I have to make sure of the safety. Safety meaning what are the adverse events I can find from this treatment, if there's any possibility of infection, and the development of antibodies or the inhibitors. What about this was the pharmacological treatment. What about the non-pharmacological? We all know the short term, it's the price, the protection, rest, ice, compression, and elevation, and rehabilitative physical therapy. Physical therapy, a physical therapist should work hand in hand with the hematologist, the nurse. It has to be a comprehensive team. And what about the long term? The physical therapy must be there also. So the long term management of the arthropathy, it would include conservative treatment by physical therapy, synovectomy, and lately the orthopedic surgery. What about the recombinant aid? I'm not going to go through the development process, but let's just go into the recombinant. Recombinant factor is produced by an isolation of the gene, the human gene, and then it has to be inserted in a cell line and going to the culture for the growth. And then the clotting factor are extracted, and they pass through different purification steps. And second and third generation need nanofiltration in order to make sure that there proper eradication of any infection. So what's the difference between first, second, and third generation? The first generation, the culture could be human or animal, and it contains albumin. While the second generation, there is no albumin, though it's the culture is human or animal. But the third generation, it's completely free, no human or animal culture medium, and no albumin. And the extended half-life is considered as third generation. So hypothetically speaking, if there is possibility of infection, or then it could be from the culture media or from the growth factor. But the third generation recombinant factors do not contain animal or human components, and thus does not carry the possibility of pathogenic transmission. And the guidelines, the medical and scientific advisory board recommends the use of recombinant factors, and the European principles of hemophilia care emphasize the need for safe treatment. What about the doses? Definitely, if it's a mild case, the dosing up from 20 to 40 units per kg, moving into the more severe bleeding with higher doses. So what about the Moroctogog alpha manufacturing process? We have the 3 steps. The cell culture stage, it's albumin-free. So absence of albumin lowers the associated risks. The synthetic ligand would eliminate the potential risk associated with the murine-derived proteins. And lastly, the nanofiltration reduces potential contamination. What about switching? When do you switch from one factor to the other? Is it safe or not? We usually switch, for example, it might be due to problems, adverse event with one factor to the other, financial issues, inconvenience, modes of administration. Different things allows the physician to move from one factor to the other, but is it safe or not? Several studies were there. The incidence of inhibitor, this was among the British population, and there showed no significant difference between those who switched than those who didn't switch to the Moroctogog alpha, and the second study showing that there were no development of inhibitor and no safety concerns. So what about the prophylaxis? Let's go through the latest guidelines, WFH guidelines, emphasizing that the regular prophylaxis should be started early in life and should be considered the standard of care for all severe hemophilia. And some of the moderate hemophilia, let me just tell you that at the Pediatric Hematology Unit of Cairo University, we're approaching 50% of our patients to be on prophylaxis. Though we had the global survey stating it was 5% among Egyptian population, but now we've been working and it's almost 45 up to 50% of the population we have. And what about the prophylaxis in cases of inhibitor? The WFH recommends using imicizumab for those on having inhibitors, and it can be used also for regular prophylaxis. I'm not going to go through the prophylaxis protocols, whether primary, secondary, or tertiary, but I just want to mention that prophylaxis has definitely changed the life of those patients, had improved the quality of life, and decreased the arthropathy, and the patients are more or less living normal. And which dose to put the patient on, low or high dose prophylaxis, it's tailoring individualized prophylaxis is the main thing. And what about the Moroctogog alpha? We've been using the low dose prophylaxis among our patients, and we have seen marvelous results. And as we see from different studies, that in cases with prophylaxis, the frequency of joint bleeds has decreased. But what is the optimum time to start prophylaxis? Definitely it's as early as possible, because you're trying to preserve the joint as much as you can. And as we can see that usually the joint affection starts by the 2nd year of life. And as we can see from this publication, that the joint affection starts 16% within the first year and a half. So I believe starting early is of the utmost benefit, because you have to preserve better joint outcome, better resolution of arthropathy, I mean. So at the end, the child can have regular school attendance, regular physical activity, and he can be more or less a normal citizen in the community. And it's the importance of individualizing prophylaxis is the utmost regimen too, because it differs from one person to the other and according to the therapy used. So individualizing prophylaxis is really cost effective. But for how long would we keep the patients on prophylaxis? There are lots of debates and lots of studies, but actually it's some papers recommended when they reach adolescence, if you started early in the pediatric age group, and others, but the most prevalent is to maintain the patient on this prophylaxis regimen all through. As we know that the main joint affection are the large joints, like the knee is the most affected joint, but what about after prophylaxis? After prophylaxis, the joint affection has moved to minor joints like the ankle. So the benefits of individualizing prophylaxis, it's important to manage the affected joints, potentially improve the quality of life, and it's more effective use of all resources and to allow the patient to achieve individual goals. And in summary, hemophilia is a lifelong disease with high morbidity and psychosocial problems. Evolution of coagulation factor replacement therapy has focused on maximizing the pathogenic safety, and the risk is low with the recombinant factor. The safety of switching of Moroctogog alpha from other replacement factor 8 replacement products has been confirmed. Regular prophylaxis started early in life is considered the standard of care for all patients with severe hemophilia. Individualizing prophylaxis based on clinical tailoring has proved to be cost effective. And thank you.